Okay. Hello and welcome along everybody this evening to this AMA sponsored webinar, which is going to be delivered by Holly Protoolis from Headspace regarding early psychosis. Now I know we've got people from all around the state, so welcome. And before we start, I'd like to formally acknowledge that we're meeting on the traditional grounds in the city, at least, of the Whadjuk people of the Noongar Nation, and like to pay our respects to elders past and present. My name's Helen McGowan. I'm an old age psychiatrist and I'm the psychiatry representative on the AMA Council, so I've been asked to moderate this evening's webinar. But I'd like to introduce you to our speaker this evening, who is Holly Protoolis. And Holly is the Community Education and Awareness Officer for Headspace Early Psychosis. She's completed her Master of Public Health in 2019 at Curtin University and has a background in health administration, health promotion and rural health. And she's here to talk to us this evening regarding Headspace and their early psychosis programs and approach. So before I hand over to Holly, just to remind you that at the end there will be an opportunity to ask some questions, and Holly has also received a couple of questions from people prior that she'll be addressing during the webinar. So welcome along everybody, and I'll hand over to Holly.
Awesome, thank you so much, Helen. So hi everyone, I'm Holly. As Helen said, I'm the Community Education and Awareness Officer for Headspace Early Psychosis. So just, hang on a minute. There we go. So just before I begin, I'd also like to acknowledge that we are meeting on the traditional lands of the Whadjuk Noongar people and pay respect to their elders, past, present and emerging. So what this webinar is going to cover today is what is Headspace Early Psychosis, what is first episode psychosis, what is at-risk mental states, the link between drugs, trauma and psychosis, and how does Headspace Early Psychosis work, what's our service structure, assessing and referring vulnerable young people, and considerations when making a referral. And if you do see me take a sip of water occasionally, I apologise, I am recovering from a cough, not COVID related thankfully. My partner is a nurse and he brought it home. So first off, a lot of you have probably heard of the Headspace model, or just Headspace in general, as the Youth Mental Health Foundation. So we call that, to differentiate it between that and early psychosis, we call it Headspace Primary. But essentially they have a highly accessible youth-friendly service that provides evidence-based interventions and help to young people aged 12 to 25 years. They focus on early intervention, it's free, they provide co-location for MBS bulk billing practitioners, and it's kind of a short-term service for mild to moderate mental health conditions. This is not a high-risk service, it's not a crisis service, it's really all about that early intervention. And comparatively, Headspace Early Psychosis is a comprehensive early intervention mental health service for young people experiencing a first episode of psychosis or who are at high risk, ultra high risk of psychosis. And if you haven't heard that term before, it's what we would also call the prodromal phase of psychosis, but because prodromal is a retroactive term, we use ultra high risk instead. So this has been developed based on research provided by Orygen through the Early Psychosis Prevention and Intervention Centre. So the model is called the EPPIC model, which is what we use. It's a federally funded national program, so it exists all over Australia in various locations, and we provide specialist support exclusively for psychosis. So this is just a bit about the EPPIC model of care. I won't go into it in too much great detail, but it just gives a good overall look of what we're trying to do with our service. The most important things are the aims, which is early detection, preventing transition, restoring normal functioning, and we do that through the core functions there: early detection, acute care, and recovery-focused interventions. And you'll hear me harp on a lot about recovery-focused and functional recovery because that's really our major point of difference. So, as I said, the program aims, the main one is early detection of young people to reduce the duration of untreated psychosis. So if you remember nothing else about Headspace Early Psychosis, I encourage you to remember that, because that's probably the most important thing. We also want to reduce the risk of transition to full threshold psychosis, or to delay and or attenuate the impact, restore normal developmental and functional trajectory, and minimize the impact of a first episode on the young person, their family, and the wider community. So we don't just have a young person in service and go, okay, well, that's the only thing we're dealing with. We kind of try and make an impact at all levels. So we do that through our 16 core competencies. Again, I won't go through all of them in sort of great detail, because they're relevant for different stakeholders and different parts of the service. But I suppose the one we'd focus on with general practice would be things like providing easy access to service, sometimes medical treatments, and obviously partnerships with general practitioners. So the reason we love early detection is because the longer the duration of untreated psychosis, the more severe the illness, the more the functional impact, and the longer it takes to recover. So relapses in the first 2 years of illness are associated with poor outcomes, longer recovery, and a greater impact on functioning. So we basically want to catch it as early as possible. I'll go through a little bit of the inclusion-exclusion criteria of the service. So they've got to be 12 to 25 years inclusive. Basically, that just means if you get the referral in the day before they turn 26, we're good. It needs to be within the 3 catchment areas. So this service operates north of the river and the Midland and sort of East metro area. Having said that, if you're not currently practicing within one of those catchment areas, that's completely fine. We're going to go through some other stuff that's relevant in terms of engaging and assessing young people who may be vulnerable to psychosis or are experiencing it. And if you're south of the river, that's covered by government early intervention services. So there's one in Bentley, Fremantle, Armidale, and Rockingham. But they're run by the government and they're run on a different model. So the young person needs to have an address within those catchment areas. And they need to be either at ultra high risk of psychosis, which has a 6-month duration of service, or experiencing a first episode psychosis, which is 2 to 5 years duration of service. And we don't boot people off once they turn 26. Once you're in the service, you're in. So exclusion, the most important one would probably be more than 12 months of treatment for psychosis. And what we mean by that is medical treatment. So we're not talking about if they've been seeing a psychologist for the last 12 months or something. And even if they've been on antipsychotics at maybe kind of a sub sort of useful level, or maybe it's just been they've trialed a few over a couple of months, that's fine. What we're talking about here is we're not going to take people who are already sort of on a long-term depot injection, or who've maybe moved to clozapine, because at that point it's no longer early intervention. Present with symptoms only in the context of substance intoxication. This one's the most often misunderstood. We do take drug-induced psychosis. However, if they are only behaving unwell when intoxicated and then as it wears off, they return to normal, that's different from drug-induced psychosis. If they're more likely to benefit from another service or program, so occasionally we have Indigenous young people who do prefer to go to specialist Aboriginal mental health services or Derbyarrigan counselling, and that's okay, we'll support them and facilitate that for them. And if they're outside of catchment area for service, we also can't take young people who are currently experiencing homelessness. However, if they are in supported accommodation north of the river in the Midland area, that's completely fine. They just need to have an address. So I'm going to go through first episode psychosis and the model of psychosis. And the reason I do that, and I even do this when I'm giving training to psychiatric registrars in the hospital, is because even amongst medical practitioners, there is still a misunderstanding about what psychosis is and what it entails. And it also helps to create a shared understanding. So by looking at how we view psychosis at Headspace, you can see why we build the model the way that we do. So first episode psychosis is a mental state in which the individual experiences a distortion or loss of contact with reality. And when someone becomes unwell in this way, it's called a psychotic episode. Most likely to occur in young people. Around 3 in every 100 young people experience symptoms of psychosis, and it can happen to anybody and it can be treated. So this is the phases model we use that comes from Orygen, and it's quite a nice model. So it starts with that at-risk mental state, which we'll talk about a bit more later as we go into the ultra-high risk stuff, which, as you can see, is just before that time where there is the onset of the first psychotic episode. So for the purposes of the model, we consider the onset of illness to be the beginning of at-risk mental state. So not the time when they have their first acute episode, because it's building long before then. And then, of course, you have the acute episode if that's where they reach. And then, hopefully recovery and ongoing recovery with hopefully not too many relapses. And the point of the ultra high risk part of the service is to kind of cut off that line at ultra high risk so that the severity of symptoms don't keep going up while the functional ability of the young person keeps going down. So sometimes when I talk to people about first episode psychosis, I do get the response, I know what schizophrenia is. And schizophrenia is just one part of psychosis. That's kind of the long-term chronic stuff. But first episode psychosis encompasses a whole range of conditions, which includes brief psychotic disorder, bipolar disorder with psychotic features, major depression with psychotic features, borderline personality disorder / emotionally unstable personality disorder, whichever term you prefer. And oftentimes you may have somebody who just has a first episode psychosis that just has one and gets well and it never happens again. We do see that. So it's not all schizophrenia. That is sort of the later chronic type of psychosis that we would see. Now, the reason I have a special slide on borderline personality disorder is that there is this perception, even amongst mental health services and in the literature, that people who experience BPD do not experience true psychotic features, and that is not true. They are true psychotic features, and there's peer-reviewed literature to back that up. And the reason why we may not have too many in our service, people living with BPD, is because the service, the not-for-profit service, the government service that runs dialectical behavioural therapy has a requirement that they can have had no intervention by another service before seeing them. So the reason why, even if we have somebody with a legitimate psychotic features to their BPD, we may refer them on, is not because we don't take them or because we're not interested, but because that service might be more appropriate and it requires that that young person have not spent any time with the previous service because they're all about the early intervention as well, but they have much more strict inclusion criteria, and we will facilitate a referral to that service. So when we talk about the symptoms of psychosis, and again, some of these are going to seem perhaps a little obvious, but again, the reason I go through them is to create a shared understanding and also to perhaps point out presentations that might come across a bit differently depending on the young person. So we have our positive symptoms, an experience extra to what most people have, and negative symptoms, which indicate something has been taken away. So the biggest ones kind of associated with psychosis are these positive symptoms. So delusions, these are false beliefs. They can be bizarre or very unlikely, like their parents are not really their parents, or grandiose beliefs like they are a god. They can start off quite simple and gradually become more complex. To give you a case example, we had a young person who was kind of quite concerned that they had dropped an electronic device with a lot of their personal information on it and kept talking about it. And initially that was not considered strange, because I imagine if most of us dropped our phones or something somewhere on the street, we'd be a little concerned about getting it back. But as time went on and this young person kept talking about it over and over again and was fixated on it, they came to realize that this was actually a delusion, that this device had never existed and that they had never lost it, but they were fixated on it as a delusion. And these can often also take the form of experiencing things like they think the TV or radio have special messages for them, or the news, for example. And it's very hard to redirect somebody from this topic. It's really best not to get into in-depth conversations about delusions. And you also need to determine what is a delusion and what is culturally consistent with the young person, and we'll speak a bit more about that later. So hallucinations. In psychosis, a person may hear, see, smell, taste, or feel something that is not actually there. They may hear voices when no one else is around, or they may see things other people can't see. Things might taste bad as if they are poisoned, and that feeds into a very common delusion that somebody is trying to poison the young person. And unfortunately, if they're also hallucinating a bad taste, that can sometimes confirm the delusions that they're having. So if they have a delusion that someone is following them, and then they have a hallucination that somebody is standing there, they can feed into each other, which is really quite dangerous sometimes. So cognitive changes, this is probably the most common one that I get when I do training, where people tell me that they didn't know this. But it's, real thought disorder. Their everyday thoughts become confused or don't join up properly. Sentences are unclear. Thoughts appear to be speeded up or slowed down. Their thoughts are racing. Their mind's jumping all over the place. And this can be really, really tricky to determine if the young person has autism spectrum disorder, or if they're undiagnosed with autism spectrum disorder. So we see those two things overlap really quite commonly. And there is, quite a significant correlation between the two. And we do a lot of work in conjunction with Autism WA. So that's one thing that might be difficult to determine if you know that the young person has a diagnosis of ASD. Behavioural changes, so things like lethargy or agitation, change in sleeping, change in eating, a change in day-to-day activity. I was actually listening to the health report with Dr. Norman Swan in the car the other day, which is a perfectly normal thing for a 25-year-old to do all the time. But he was actually presenting a study that had been done over East by the University of Newcastle, where they had looked at the association between sleep pattern issues and disorders and mood disorders and psychosis. And they actually found that there was quite a high correlation between the two. So that's a really important one, is how they're sleeping. And that can be difficult with teenagers because, of course, teenagers tend to have a very erratic sleep pattern anyway. We also see emotional changes. So being emotionally labile, having that lack of emotional expression, what we call that really blunted affect. Again, really difficult to determine if the young person also has a diagnosis of ASD. That can be quite a tricky one. Having an incongruent affect, grimacing, smirking, laughing, expressing a different emotion than what they say they're feeling, and they may be more irritable and angry. So now that we've looked at first episode psychosis, and the reason I guess I do first episode psychosis first is because now we're going to look at that ultra high risk prodromal phase, and it's easier to see what those attenuated symptoms or bleed through symptoms might be if you know what the full threshold symptoms look like in quite a bit of detail. So that's why I do the first episode psychosis first. So at-risk mental state is kind of early warning signs that are often non-specific, vague, insidious, and can resemble stress or adolescence, normal adolescence, and there could be changes in how they describe their feelings, thoughts, and perceptions. So if you remember back to that phases model we had the ARMS, the at-risk mental state, and then the ultra-high risk kind of just before the acute phase. So what that really looks at, the signs associated with that part of the illness, is a significant decline in functioning. So withdrawal from social circles, losing jobs, stops attending schools, or grades diminish. And attenuated symptoms might develop. So unusual thought content, delusional mood and perplexity, ideas of reference, things having special meaning, perceptual changes, and some difficulty with verbal communication. It's important at this point to kind of differentiate between what might be a social anxiety and what might be an attenuated symptom, because that is one thing that often gets mixed up. So for example, if a young person says to their GP, I feel uncomfortable in crowds, I feel like everybody is watching me, I feel like everybody's waiting for me to mess up, that's not paranoia, because that belief is not entirely bizarre or unreasonable. I mean, people are watching other people in a crowd. That is more symptomatic of social anxiety. However, if they said to you, I think one person, a person is following me and can read my thoughts or is tracking my movements, that is when it starts to stem a little more to the paranoia side, because it's an unusual, sort of bizarre belief to have. So our ultra high risk category at Headspace Early Psychosis, when you refer to us, is based on having one of these following three plus that deterioration in functioning. And the deterioration needs to have happened sort of in the last six months-ish, I would say. And so you need to have those attenuated symptoms that we just spoke about, or brief, limited, intermittent psychotic symptoms. This is not a common presentation, but we put it in here anyway. But what it means is people that have full threshold psychotic symptoms, but they last for a very short period of time, maybe a day or two, without drug or alcohol, obviously, and then they go away on their own without any intervention. It's not a very common presentation, but it does happen, so it's in there. And then if they have a trait vulnerability for psychotic illness, so usually we would take this as a family history. And this is not exclusive to the first degree relatives necessarily. So if a young person says to us, mum, dad, brother and sister are all completely fine, but I have 5 cousins diagnosed with schizophrenia, that's enough. That's enough of a family history. And in particular, if there's a family history and they've begun to abuse substances and there's that deterioration in functioning, that's when we become very interested in seeing them, because they are a prime candidate to develop psychosis, and we want to stop that as soon as possible. So that's the criteria for referral. Once the referral is accepted at triage, then there'll be a comprehensive assessment to determine if we're the best service for the young person. And the reason we have this ultra high risk stream is that it's a preventative stream. So we do prevention as well as care. The rate of transition in a 12-month period from UHR to FEP, first episode psychosis, is 21%, which is 300 times greater than the general public, which is, a lot. And our intervention is targeted at the same things as first episode psychosis. So minimizing disability and adverse health, enabling recovery before symptoms and functioning become entrenched, and preventing, delaying or ameliorating the onset of a full threshold psychotic disorder. And the interventions for that would be similar to some of the stuff we do for first episode psychosis, which I'll talk a bit more about later, but things like CBT, psychoeducation, case management, family work, and psychopharmacology if it's necessary. That doesn't usually mean antipsychotics. It would be pretty unusual. That usually means maybe something like an anti-anxiety or an antidepressant if it's found to be necessary by our psychiatrists. So a note on voices, because again, when we get referrals, particularly for ultra high risk, we often get people that say, oh, this young person's hearing voices. And that is most commonly associated with psychosis. However, it's not uncommon across a range of settings to be hearing voices, and it doesn't necessarily mean they have psychosis. So it could be part of trauma, grief and loss, dementia, unusual in the 12 to 25 population, but you never know. Delirium, faith-based, culturally specific, or while intoxicated. So an example we have of that is we had a young person who came in and said they were hearing voices in the referrals. Obviously, we took them to assessment, and it turned out that the voice hearing was happening at one parent's house, but not the other, because the parents were divorced. And so it turned out the voices were happening in the context of a very dysfunctional family environment in one home, but not the other. And that is not a psychosis sort of presentation. That's probably more to do with trauma in that instance, and we referred that young person onto a better service for them. So this sort of section of the presentation talks a bit about the causes of psychosis. But I will also talk about things like sort of trauma and drug use, because so those were the ones I get questions about. I got questions about for this, and also that I probably get questions about a lot of the time, especially for drug use. So I will go into that for the people that ask those questions. So there are a number of theories about what caused psychosis. There's some indication that it's a combination of biological factors in early development. There can be medical causes, drugs, stress, and trauma. And we use a model called the stress vulnerability model, which is a really good way of explaining to young people why it is that some people experience psychosis and others do not, and also to destigmatize it. So this is our stress vulnerability model. We call this the stress vulnerability bucket. And I love using this in these presentations, and I know clinicians like to use it because you can explain what's happening to the young person and you don't have to use the word psychosis once. Because in our service, if a young person has poor insight and doesn't want to sort of acknowledge that they may have a diagnosis of psychosis, and we do have young people like that, as long as we can get them to accept that they're having a set of experiences that is outside the norm and needs to be treated, that's fine. If they don't want to use the word psychosis, we're not going to make them. All we're interested in is getting them well again, and that's fine. So we use this bucket, and we say that everybody's got a bucket that might come pre-filled with water due to genetic loading. So maybe mum's got schizophrenia, maybe there's some early developmental issues, maybe there's some trauma, that sort of thing. And then the things that are being poured down by the clouds there, so stuff like a lack of sleep, financial issues, family stress, anxiety, they fill the bucket up. And after a while, the bucket overflows, and that's when you start to have a presentation of psychosis. And some people have, you know, not very much preloaded in the bucket, but with enough stress and with enough stuff going on, their bucket would overflow just the same as somebody whose bucket was almost filled to the brim. It would just take a lot less stress for them to tip over into that presentation. And then, of course, you can empty that bucket and relieve your symptoms by things like doing things you enjoy, talking to people, relaxation, attending your therapy appointments, things like that. And it's a really good way also to explain to families what's going on, particularly if we start hearing the families using words like psycho or schizo, then we whip this straight out because it's a good way to explain it. So trauma and psychosis, I did get a question about this. So we understand that a lot of young people with first episode psychosis have experienced some kind of trauma, and you need to consider the young person's context and history when thinking about the nature of their psychosis. And the experience of acute psychosis itself is a trauma, particularly if they have been involuntarily hospitalized. That's really another reason that we emphasize early intervention, because we do not want them to have that experience of being put under the Mental Health Act. It's not pleasant. And I guess it's also important to think about their particular kind of background of trauma. So we have a lot of young people in the service whose trauma comes from having a refugee or asylum seeker background, or even just the process of migration from a country where there's been civil unrest or persecution and things like that. And those can be very tricky to deal with because it's very hard to even get the family to discuss that. You know, we have some families where we still don't know what their story is just because they won't talk about it, but we can see that the young person is extremely traumatized. So it's something that's always in the back of our minds. And if there's any comorbidities like post-traumatic stress disorder or stuff like that associated with the trauma, we will treat those things too. So we don't just treat psychosis. If there's comorbidities, we'll help out as best to our ability. Drugs and psychosis. This is the one I get the most because obviously of the strong association between cannabis and amphetamine use and positive symptoms. And that, of course, drug-induced psychosis is probably one of the more predominant reasons that we have young people in the service. So I was asked a question about how we deal with drug use, as opposed to just saying, just don't smoke, just stop, it's bad for you kind of thing. And I spoke to a couple of our case managers about this. So as part of the Orygen model, we use psychoeducation. So the idea is to non-shamefully and non-judgmentally, but honestly, take them through the logical progression of what will happen if they continue to use in a way that's relevant for the young person. So particularly for people who have been hospitalized before, we sort of take them through, if you continue to do this, the natural consequence is that you will relapse and you will end up in hospital. And that's enough a lot of the time to at least reduce the usage. So we don't ask for miracles. We know that young people are still going to use sometimes, but when we can reduce somebody from polysubstance abuse to a bit of cannabis during the week, that's a major success. And also kind of taking them through the progression of, if you keep relapsing, this will stop being a first episode psychosis and this will become schizophrenia. This will become a long-term, lifelong, chronic illness that you're always going to deal with. And that can be really hard to hear, but we're very honest with them. In saying that, we also really try to have a non-judgmental approach. So we make it very clear to the young people that we will not tell their parents, we are not going to shame them, we are not going to judge them, but we do need to know if you've taken substances, particularly if you're on a depot. And also educating them that antipsychotics, while they are wonderful, they're not a magical drug that will stop or counterbalance the effects of cannabis and amphetamine use. Pardon me. I guess each approach is really individual to the young person and the case manager involved and what their preferred approach is. But I guess we also try to have unconditional positive regard and hope in terms of drug use. So we don't tend to think of it as a hopeless case, or they're always just going to sit in their room smoking weed, this, that, and the other. We don't speak about them like that, even within our own service, which helps a lot in because how we perceive the young people is reflected in how we care for them. And that's a really important part of our service. Oh, sorry, I probably should have gone to this slide after, but yeah, so there is obviously evidence that drugs increase the duration of untreated psychosis, because of course you present to a hospital like that and the first thing they're going to do is think, okay, is it drugs? Let's get them a tox screen. Do they need to just sleep it off? They'll develop more severe positive symptoms and have an increased number of relapses if they continue the drug use. So this is something we do tell our young people. We're very honest with them. We say, look, this is the progression. This is what happens. But we're not trying to take a parental role. We're not their parents. We're not there to nag them. And that can sometimes make all the difference, just the fact that we're there to listen. So we're going to get into the actual early psychosis model and how we treat young people in our service. So even if you're not in the catchment area for our service, this is still useful because there are things in here that you may be able to adapt in your own practice. And there are also some strategies for facilitating engagement that will be helpful for anybody. So obviously our service is structured into two streams, ultra high risk and first episode psychosis. So we work on a hub and spoke model. So there's 3 centres in Perth where HEP is located. So Joondalup is the hub, which is where I'm based a lot of the time. And then Midland and Osborne Park are the spoke centres. So there's a mobile assessment and treatment team based in Joondalup, the MAT team, but they work across all 3 sites. They go everywhere. We have the continuing care teams. We've got 1 at each site. And functional recovery program, which is again across all 3 sites. They go everywhere. So the mobile assessment and treatment team, if you refer to our service, these are the people you will come into contact with first. So these are the people who triage referrals. They do the assessment for HEP services. They'll do assertive follow-up with extended hours of service. So they work until 7 on the weekdays, I'm pretty sure. And then they do work weekends, Saturday and Sunday as well. There's always someone there. And they work intensely sort of in the acute phase to engage and stabilise them. They do joint assessments with other services. They have in-reach into patient settings. So this is important. For a lot of the hospitals in our catchment area, we actually have a service level agreement with them, and members of the MAT team are assigned a hospital, and they actually go to their stand-up meetings and ward rounds. And the doctors might say, oh, I think, you know, we've got someone here who'd be suitable for your service. And part of my job is actually going in every August and February when the registrars rotate to give training to the registrars about our service and how to refer. And they'll also, MAT team will also identify alternative services where HEP is not the most appropriate service. And the MAT team's got a lot of people who have come from CAMS and other services like that. So we have a lot of really good connections to other services if we are not the appropriate service. The assertive follow-up is probably the most important thing, because obviously the biggest thing with young people experiencing psychosis, my apologies, is the engagement. You know, especially from a general practice perspective, where you might see them for an appointment and then you might see them again, you might not, or you'll have mum or dad or someone else concerned on the phone saying, or in an appointment saying, you know, this and this is going on, I've got no idea what to do. So we are not a crisis service. So if you do have someone who you feel is a danger to themselves or others, you need to call your local community mental health team so that they can be placed under the act if necessary, or try and convince them to go to emergency. However, once they are known to our service, the MAT team are the people that will help them and form them if necessary. They do all that with their assertive follow-up. And that also means that if you've got a young person that doesn't want to come into the centre to be assessed, that's fine. They can be assessed in their bedroom. They can be assessed via Zoom. They can be assessed at school, at work, in a park, in a cafe. I know we've done one in a pub. It's not recommended, but it was the best way to engage that young person at that time. And although we can't force people to come and see us, unless they are on a CTO or under the Act and we've been assigned as their treating team, because we do take people who are on CTOs, we do have a bit more scope. So for example, we had a mother ring the head of our MAT team and say, look, I'm very concerned about my child. They are over 18, so I can't sort of make them do anything, but they're acting very strange. I'm so concerned that they won't speak to anybody. So the head of that team said, okay, can you get them to a place near the centre, a cafe or something, and then just tell them that I'm just going to pop along just to have a few words with them. So, you know, they did say to the young person that someone from Headspace Early Psychosis would be talking to them. It wasn't done without their consent. So that's what the mum did. She got the young person to a cafe near the centre, and then the head of the MAT team went over and took one look at this young person, and they were quite obviously floridly psychotic. And they'd actually opened up a slot, and they got that young person into the centre to see a psychiatrist that day and on some oral antipsychotics, which was great. And that young person's now in our service. So the MAT team's made up of nurses, psychologists, social workers, OTs, and then they have their own consultant psychiatrist and a registrar, because we are part of the training rotation. Then you have the continuing care team. So once that kind of acute phase has been contained, they'll be assigned a care coordinator and a doctor. So each continuing care team at each site has their own consultant psychiatrist and their own registrar. But I think we share, one of our registrars shares between Joondalup and Osborne Park. The exception to this is also Midland. They have a consultant psychiatrist, but they also have a developmental paediatrician who specialises in paediatric psychiatry. So that's a bit different between each of the sites. So they provide the ongoing care to the young person. They develop care plans. They provide psychoeducation and evidence-based interventions like CBT. They deliver family support, support access to functional recovery, treat comorbidities, manage community treatment orders, and do medication monitoring. And similar to the MAT team, the continuing care team's a mix of mental health nurses, psychologists, OTs, and social workers. And, you know, if the practice nurse for HEP is at another site that day, one of the case managers who's a nurse will sort of take over the depots for the day, and we all kind of share the work around. So having a case manager is a bit different to just having a therapist that you might see once a week for an hour, and then, you know, you see them when you have an appointment. They are available, you know, all their working hours, and they always will get back to a young person or the family. They are free to call the case manager at any time. Young person's free to call and request a case management appointment, request a phone call, request a Zoom. It's not like they're stuck with their once a week or twice a week or whatever it is we've decided is appropriate for them. And it's a bit of a different relationship because the parents can call the case manager. However, if the young person is over 16, they do, or, you know, even if they're a minor, we will respect it unless it's something that really the parents need to be told. They get to decide how much their parents are told by the case manager, and that's a negotiation between the case manager and the young person and the family to create a shared understanding around confidentiality. So they do a lot of work around that. And they run on this case management model. And I guess the most important thing is that if we have a young person that is not interested in looking into the deep, dark psychological issues about why this has happened to them, we're not going to make them. If they just want to have the medication, functionally recover, get better, and then never see us again, that's fine. They functionally recovered. If they don't relapse again, amazing. If they do, they can always come back. But we're not going to force people to do things that they don't want to do, I guess. We'll encourage, but we're not going to make people do things that they're not comfortable with. And then we have the functional recovery program, and they provide our real point of difference, which is the functional recovery. So we have groups programs, which are art therapy, voc ed groups, recreation, things like rock climbing and stand-up paddleboarding, fun stuff like that, and targeted psychological interventions in a group setting. We have a vocational education program coordinator who has to adhere to the individual placement model, which has to be done to quite high fidelity, and that's about getting young people back into work and school so they can negotiate with TAFE, with uni, with school, with work, with anybody. They can come into appointments and speak for the young person if the young person's not able to speak, help write resumes, help apply for jobs, help with Centrelink, everything. Then we have peer support workers and youth engagement. The peer support workers are extremely popular. What they are either young people who've gone through a first episode psychosis, who now work for us, or parents who have a child that's gone through a first episode psychosis. Because if you say to a family, do you want family therapy, which we do offer, they'll probably say no. But if you say, do you want to speak to a mum that's been through this, they're going to say yes. And one of our peer support workers has actually been through our service and experienced drug-induced psychosis. So they are invaluable when talking to young people about drug use and psychosis. So they're probably the most popular person in the service. And we also have a youth engagement officer who does what I'm doing now, but with young people, and a youth reference group who we bounce ideas off of, and they tell us if we're being uncool or not, basically. And then there's other things, other roles working across all the teams. So we have a senior clinical psychologist, senior family therapist, family worker, a practice nurse, community education and awareness, which is me. So I work across all 3 sites, and a cultural diversity clinician who helps with any culturally and linguistically diverse young people we might have, as well as facilitating relationships with culturally and linguistically diverse people within the community. Quick note on the role of family workers, because again, this is something I get where maybe a practitioner can help the young person, but because there's so much family dysfunction, it's kind of impossible to get them to stay well because the family is a big contributing factor. So we offer family services, and what this is about, it's not about family therapy, that's at the top of that pyramid there, which they can have if they want, but it's really about supporting respectful communication, family function, maximizing their adaptive functioning, and educating about, you know, relapse signs, problem-solving skills, communication skills. But the they're also there for the parents. So if the parents want to see the family worker without the young person, they just want therapy, that's completely available to them. And it's not about sitting the parents down and going, here's everywhere you went wrong raising this child. It's about, maybe challenging some entrenched beliefs about psychosis, or about how you treat a young person living with psychosis, and respectfully and slowly but surely restoring as much function to the family as well as the young person, which is really important. So as GPs, if you refer to our service, what do we expect, or would like rather, from you? So the GP, we often like to have managing the physical health of the young person in liaison with the practice nurse, because we do have a practice nurse, but there's one of her and 3 sites. We also send out letters every 3 months to the young person's GP to update them on what's going on. If you're receiving these letters, it's really, really important that you read them, because we will talk about things like, hey, don't prescribe the young person XYZ, please. And we've had sometimes where that's not been noted, and then the young person has been prescribed something that they shouldn't have. So that's important. To work with the case managers as much as possible, to provide info to triage on referral if you are the referrer, and also if the young person's well, quite often they are discharged to the GP, and that will be a conversation at the end of service. So why we want to monitor the physical health is obviously the metabolic syndrome that comes with antipsychotics. So patients with the diagnosis of schizophrenia have a 20% reduction in their life expectancy because of coronary heart disease is a very significant factor. So of course they have metabolic side effects with their antipsychotics, such as weight gain, hyperlipidemia, and effect on insulin function, which can independently contribute to coronary heart disease. So I think probably the most common thing we send young people to the GP for is for things like bloods, EKGs, ECGs, I always get mixed up between the two, I apologize, but heart health monitoring basically, and medications that are not, antipsychotics. So probably the most common thing we send them to their GP for is metformin, if they're experiencing insulin function issues. So I'm just keeping an eye on the time. I might have to go through this a little quickly, but these slides will be made available to you if you've attended this. So when we assess and refer vulnerable groups, the groups that we sort of really look at are Aboriginal and Torres Strait Islander youth, culturally linguistically diverse youth, LGBTQIA+ youth, and youth living with a disability. So before we just go into that, it's always really important to keep this at the back of your mind if you are seeing Aboriginal, or Indigenous young people rather, in terms of, instead of using the term mental health, tend to use the term sort of emotional well-being, or social, emotional and cultural well-being, because it's sort of a more holistic view of health. So it's really important also to establish with the young person, if they have identified themselves as Indigenous, what depth of sort of connection they have with their culture, and not to generalize what their experiences may be, but just keeping this in the back of your mind if you are seeing a young person that's identified themselves as Indigenous. So we'll go through each vulnerable group with the barriers and risk and the engagement strategies that have either come from peer-reviewed literature, consultation, or Orygen itself. So for LGBT young people, they're twice as likely to be diagnosed with a mental health disorder at a higher rate than older LGBT people. Barriers to service include fear of harassment and discrimination, a fear of being outed to their family, and shame associated with the exploration of identity, particularly if being LGBT coincides with something like belonging to a culturally or religiously diverse community that is perhaps not as accepting of LGBT young people. And the way that we would ask, or the way that we like to engage them, is to work in an inclusive way, use gender neutral language, always ask what terms they prefer, address their concerns about confidentiality, discuss matters of cultural and religious diversity if it's relevant, and consider sensitivity of information when having discussions in front of family. So if they have disclosed to you that they are gay or that they are identifying as transgender, wait for them to bring it up in front of their parents before you do, or ask outright the young person on their own, are your parents aware of this? Is this something I should keep to myself? Because you just don't know. And it can be a really unfortunate and sometimes dangerous situation for young people if they're inadvertently outed. With Aboriginal and Torres Strait Islander youth, obviously there is the risk of a higher prevalence of mental illnesses when compared with non-Aboriginal youth, higher levels of trauma and grief causing psychological distress. There's a shame associated with help seeking, a distrust of mainstream services, higher levels of substance misuse, and an interplay between cultural beliefs and symptoms. So what I mean by that is there can be amongst some Indigenous young people, and again, this is a slight generalization, but they can have this sort of attributable cause and effect attitude to health. So if you are mentally unhealthy, it could be because you have done something perceived to be culturally wrong, or you've done wrong to another person, and this is the punishment for it. Again, that's not going to be true for every Indigenous young person, but it is something to keep in the back of your mind. So most important thing is have an open discussion about their identity, to what level that they're sort of integrated into their culture. Acknowledge your cultural differences between practitioner and patient. This is nothing wrong with saying, obviously, there is a difference between us, and asking how they feel about that. Being mindful of cultural barriers to engagement, such as gender differences. So it may be inappropriate for opposite gender practitioner and young person, if they're Indigenous, to maybe sort of be speaking. They might be more sort of withdrawn with you. It may be more appropriate for them to have somebody of the same gender. And it also depends on their local, like if it depends what their particular language group or family is going through in terms of law time, or if they're going through any sorry business or anything like that. It's important to keep those things in the back of your mind. Discuss their family and who their main supports are, and be aware of cultural beliefs around authority. So, if they're looking at the ground or something like that. There's a really incredible article by the amazing Indigenous psychologist, Tracy Westerman, who developed a step-by-step tested and proved method of engaging Indigenous young people in mental health services. So things like, really basic things like sitting side by side instead of one in front of the other, and placing yourself sort of geographically as well with them to make that connection if they are sort of very integrated into their culture. So for example, it's completely fine to ask, what is your country, or who are your people, and then maybe talk a bit about where you come from, particularly if you've got a culturally and linguistically diverse background yourself, and kind of build some shared understanding that way. I know that I've done this in community engagement by comparing the similarity between Aboriginal Nans and Greek Yayas. There is a big intersection between how the two behave, and I've built some good relationships that way, which has been super fun. So culturally and linguistically diverse youth, biggest sort of barriers and risk are the relationship between immigration and psychosis. There is an association between the refugee experience and psychosis, particularly in Australia, and particularly if we have a young person that's been in mandatory detention. It's unfortunate, but those are the laws here, so we see that quite a bit. Trauma from experiences like civil war, persecution, or family separation, language barriers, fears about confidentiality, and the cultural beliefs about mental health and seeking help. So the way that we would engage them is sort of discussing their own experiences. discussing your own experiences if relevant to negotiate understanding. So Australia is a wonderfully diverse place. Many practitioners are culturally linguistically diverse people. So you can draw on your own experiences there. Demonstrate an active interest in understanding the culture. It's perfectly all right to say, you know, I know absolutely nothing about this, but I would love you to tell me. You know, that's always nice. Working with interpreters when needed and having those contacts on hand. Discuss and investigate the potential differences between a symptom and normative cultural experience, and openly invite discussion around confidentiality. And then for youth living with disability, this is a tricky one because people often don't think that those living with intellectual disability experience psychosis, but they do. So this is all about maintaining an accessible, disability-friendly environment, removing internalized assumptions, and discussing accessibility of the individual with the young person / their carer to facilitate ease of access. And I guess just remembering that just because somebody potentially has an intellectual disability or a physical disability doesn't mean that they're not going to have psychosis. So when you're making a referral, there are a whole bunch of things to consider, but I will, just because I'm conscious of the time, say that the most important thing is level of risk if you know it, if you know of any previous hospitalizations or occurrences, because we do not have access to the government database system for risk and for notes and stuff called Solace. We wish we had access, but as an NGO, we don't. We've tried. So if you know of any risk factors, those really need to be included. So there's a referral form. Currently the Headspace website itself is being updated, but this is available on the Black Swan Health website because they're the lead agency for Osborne Park and Joondalup. Fill in this referral form, email it or fax it to the triage officer, and they will contact the young person within 24 hours, and then hopefully they'll be seen by the MAT team within 48 hours. And feel free to call the triage officer if you've got a young person that you're not quite sure about and you want to maybe discuss it a bit. They're always open for a chat and for conversation. We do work with involuntary young people, and we can work with involuntary young people, but like I said, we need to know of any risk concerns whatsoever, because that's just, unless we call Merle, we don't have access to that particular thing. So a couple of resources on this slide, but like I said, you'll be emailed these once this is over, so you can go look through these if you like. And that is the end of the presentation. So just if we have any questions that want to be answered, now would be the time to pop them in.
I know we don't have any questions that have come through on the chat line, but I don't know if anybody else wants to raise or ask a question now. And perhaps while you're thinking, if I could just say thanks very much, Holly, for such a comprehensive presentation. And certainly having worked in mental health for a long time, people often pay lip service to recovery-oriented services, but it's really clear that recovery is absolutely embedded in what Headspace does, and it's really great to see how the services are developed. Could I just ask just a simple question, is that you said something about the case managers being available at any time. Do you mean 24/7 or just during business hours? Or?
Oh, during the case manager's working hours, which they'll tell the young person, you know, it'll be 8:30 to 4:30 usually during the week. However, the MAT team is available until 7, and they're available on the weekend. So if the young person does have a problem, they can call the MAT team. So the case managers from CCT hand over to the MAT team every weekend. They do a handover. They say, can you check in on this person? This person might call you. So they are aware of everybody in the service. So if you call, and on the weekend, I think it's 9 to 5 Saturday and 10 to 6 Sunday, you will get somebody who knows you.
Right, well, thank you. And just one other question too. Does Headspace also provide accommodation support services or access to crisis accommodation or support for young people in crisis?
We certainly will, yeah. So we'll help with referrals to places like Richmond Fellowship and Nullamire and places like that. And the case managers kind of do everything. And when I say everything, I mean everything. Like if you talk to a psychiatrist that works in our service, they'll say, you know, I'm just here for the medical reviews. The case managers run this place. So they'll do everything from referrals to other services, to Centrelink, to housing, to smart rider access, to everything. So yes, and if that becomes a problem while they're with us, we're not going to say, oh, you're homeless now, we're going to boot you off the service. The case manager will find them somewhere or some crisis accommodation to stay. Even if we have to find some emergency Centrelink funding and put them in an Airbnb. We've done that before, and we get to be very inventive.
Fantastic. But we're just about out of time. So if I could just remind everybody that if you need CPD points, that you do need to, you will receive a follow-up email, and you need to fill out the evaluation form to claim the CPD points. And certainly, I'm sure Holly would always appreciate the feedback. So please take a moment to actually do the feedback. Now, as there aren't any other, oh, I beg your pardon, I've got one question from Peter Wales. Is there a difference, character to psychosis, secondary to THC versus amphetamines? Have you got?
I think before I answer, it's important for me to note that I'm not a clinician. So my answer will be based off of anecdotal experiences, because I do go to some of the clinical reviews for like background on the service and stuff, because we're very multidisciplinary, so we all know what each other's doing. From my understanding, I would probably say not. I would probably say drug-induced psychosis is drug-induced psychosis, and it tends to be the same regardless of what substance they're using. That being said, I have noticed it in the service, it is easier to give psychoeducation about why a young person shouldn't use methamphetamine than it is for cannabis. So it is easier to tell a young person to stop taking meth, and they often do. But because cannabis is kind of seen as harmless in that age group, that's much harder to reconcile with them. But from my anecdotal experience, no, if it's drug-induced psychosis, it tends to be the same regardless of what they've been taking.
Although probably what I would add is that if people are on amphetamines, they're often a bit more elevated as well. So,
oh, for sure.
So that might be some of the differences. I mean, the quality of psychosis, it depends on the relationship at the time between the symptoms and the drug use as well.
Yeah, because I'm thinking of maybe a young person that's had meth, and then like 2 days later they're experiencing symptoms. That would be the same regardless of the drug. However, if it's while they're sort of actively intoxicated, then yes, the ones that are on methamphetamine do often present a slightly higher risk and are more elevated, definitely.
Absolutely. Look, well, thanks very much, Holly, for a great presentation. And yes, for those of you that haven't done already, please fill in your evaluations and get it back to Holly. And I'm sure there'll be more opportunities to, some more webinars and some more opportunities to hear Holly talk about some of the Headspace work. So thank you very much.
Thank you. Thank you, everyone.